各位来宾、同事、朋友们，大家好。我是 Harlan Cromwell 耶鲁大学教授。I am also the editor of Jack. Let me tell you why I want to do this session on incretins. It's because this is the most important change in cardiovascular health and the potential for population health that we've seen since statins. And I think it's actually more profound. It's more profound even that, because it represents a very different idea about what we're going to do with regard to improving population health, actually treating many of the other risk factors, hypertension and hyperlipidemia. For people who are living with obesity, this may be the first choice agent. We need to be able to treat the obesity first. We can treat inflammation, hypertension, hyperlipidemia. And let me just say, we can speculate about, I'm sorry Erica couldn't be here. She had visa problems. That's why we have the video. But it was a chance for you to hear both the global perspective. Obesity is going up. It's just a reality, like hypertension throughout the world, especially with the epidemiologic transition. And then you can hear from, it was supposed to be second for Erica, talking about actually metabolic derangements. I think about obesity as a cardiometabolic problem. This isn't a problem about how you look. You know, for too long, we've been stigmatizing people for how they look, and also making people feel guilty, making them feel they fail. They don't have willpower. They can't manage their weight. What's wrong with these people? You know, and for people who don't have this problem, they can't understand. In a society where food is abundant, sedentary behavior becomes normalized. It's a condition they have, just like hypertension. Hypertension in pre-industrial societies doesn't exist like it does here. It is when people are active, they're out in the fields working, they're having trouble actually with food consumption. There's not much hypertension. Hypertension is part of a change to a society where salt, food, sedentary behavior, stress, all these things lead to that. It's the same like obesity. And instead of blaming them, we need to say they have a condition, not to stigmatize them. We need to understand how to help them become healthier. When I think about these drugs, I think about them as health promoters. I actually don't think about them as weight loss. I think about them as that way. So what you saw was, and then Chris's great talk is telling you these improvements to the heart, they are heart health drugs. They're actually changing the architecture of the heart. His paper that's coming out soon, I really recommend it to you, when it's paired with Summit, is showing you that people aren't just feeling better, but actually the architecture of the heart may change. I have to say, we can't tell you the results yet, but you will be seeing that these are changes that are occurring even in many cases before what you're seeing with weight loss. So these drugs are actually very interesting. And people will tell you they know how they're working. Erica's showing you some construct about how they work. I can tell you, we still don't know exactly how they're working. Maybe they're brain medications, but we don't know exactly how they're providing the effect. So I'm going to quickly just tell you the story here. How do we even discover that these drugs have beneficial effects? It's an accident. It's an accident. What happens? In the US, we're treating diabetes, and all of a sudden with sulfonylureas, and then with the glitazones, like rosiglitazone, people are determining that maybe they're adverse cardiovascular effects. Maybe these drugs that are lowering hemoglobin A1C are paradoxically dangerous, causing heart failure or even cardiovascular events. So this is where why did I become outcomes researcher? Because I care at the end of the day what happens to patients. And I'm seeing a dissociation between risk factors getting better with some drugs, but maybe their cardiovascular outcomes getting worse. We're starting to talk to FDA, regulatory agencies. They say, you have new diabetes drug, you have to test the safety, cardiovascular safety. Why? Because they're worried they're dangerous. So these drugs, the new drugs that are coming out, SGLT2/1 inhibitors, and the GLP-1 receptor agonists, they're being tested for safety. Safety. But what happens? Actually, they're causing lower risk. They're saving lives. People are surprised. Now they say we have to look more closely at these drugs. We didn't expect, because the benefit is larger than the reduction in hemoglobin A1C. It's leading people to say, okay, we need to start looking more closely at these. And then they notice the GLP receptor agonists. People are losing weight. They're going, well, maybe these can be weight loss drugs. Actually, they're not designed, wasn't designed, not an intelligent design for we need to build these drugs for weight loss. They discover weight loss and they already recognize they're improving cardiovascular outcomes. So now there's a whole pipeline of drugs coming down the pike that are going to be looking at this, but 2 are already approved for use in obesity. And the original trials were not outcome trials. They were saying, are these drugs effective for obesity? You know, we've never been able to treat obesity. Like I said, okay, lifestyle, we're always going to try to promote exercise, good diet. But the truth is, people with obesity almost always rebound. Almost always. Very small percentage, maybe less than 5%, can truly achieve sustained success. It's only with these drugs that we're starting to see common sustained success. And now there's going to be so many more that are going to be tested. But here, I'll go through quickly and tell you that what excites me the most is the winning streak of outcomes of these drugs. The winning streak of outcomes. STEP HF, we're seeing in patients with heart failure and preserved ejection fraction, we almost have nothing. Finerenone now, sure, yeah, at ESC, not as even, I don't think it's going to be shown as good as this. And we didn't have anything before this. Now, this drug shows significant reduction in heart failure-related symptoms and physical limitations, and the magnitude of the benefits related to weight reduction, but actually the benefit even starts earlier. And with the studies, we're starting to see favorable structural changes in the heart. In SELECT, for CVOT secondary prevention, powerful benefit, 20% reduction in CV outcomes. That's just like statins. That's incredible. People with obesity and high risk, 20% reduction. This has to be standard guideline-based therapy now. And then FLOW, patients with CKD, they said it was stopped early. 24% reduction in risk of kidney disease progression, in kidney disease and cardiovascular death. This is amazing. We're now no longer just seeing lab tests benefit. We're seeing incredible outcome benefit. So this is this study that comes out that looks at STEP in preserved systolic function, STEP HF. First, it comes out in New England Journal of Medicine. But we're also publishing papers. This is a JACC session, I'm telling you. I told the JACC team, this is a revolution in treatment. This is going to be such a remarkable tool to be able to help patients. So we're publishing a lot of papers. This paper is showing an interesting finding. Women actually have more weight loss on these drugs, similar cardiovascular benefit. People talk about the correlation with weight loss, but the truth is there's also benefit here that's accruing that's not always so associated with weight loss. It's quite interesting. We published the inflammation paper Erica talked about. One in atrial fibrillation, heart failure with and without atrial fibrillation, consistent benefit. We published the paper Chris talked about with ECHO. The SELECT study I thought was very interesting. This is a secondary prevention study presented at AHA last November, published in New England Journal of Medicine. Again, I'm just emphasizing this. 20% reduction in CV death, non-fatal MI, non-fatal stroke. This is quite impressive. The number needed to treat is 67, but of course, the higher the risk, the more that benefit is going to accrue. But look, early separation, even before they're losing weight, the risk is starting to separate. It's not like, okay, they are the same risk and then it separates as the weight loss occurs, but even early on, you're seeing this. And this is also important in SELECT. The reason that the number needed to treat is as high as 67 is because this group is being treated very well with secondary prevention medications, statins, platelet aggregation inhibitors, beta blockers, ACE inhibitors, ARBs. They're being treated with guideline-based treatments. Very, very good treatment. And still, you're seeing 20% reduction in risk. Still, you're seeing a number needed to treat of only 67. We published, again, this looking at sex differences in SELECT. They also, like I said, more weight loss, same benefit. Raising the question of these drugs having, remember we talk about statins, pleiotropic effects. Are there effects beyond lipid lowering? I'm asking the same question here. Are there effects also additive that are causing above what we're seeing with weight loss? Interesting, we're also showing that time to heart failure in these events. I'm just going to go fast because we're at the end. There was an interesting paper that came out. SELECT is being run during the pandemic. Quite an achievement that they finished the trial during all of the disruption of the pandemic. And so they show this in their trial. If you look at the right, death from cardiovascular causes, look, it separates early, but then it comes together. I think that's the pandemic time where there's competing risk. So actually the drug's not as effective for cardiovasculars because people are dying of a lot of other things. It becomes the third leading cause of death in the SELECT trial. The COVID becomes third leading cause of death. They published a paper in JACC. Compared to placebo, patients treated with semaglutide had lower rates of all-cause death that was driven principally by similar reductions in CV and non-CV deaths. They have lower risk of death from infection. It's actually protecting them from COVID. They have fewer COVID deaths. So again, in US at least, people with obesity had the highest risk for death with COVID. They were the most susceptible. It turns out you treat the obesity, the risk went down from the pandemic. This is showing you all cause. Cardiovascular, like I said, came together. But look what happens on the third one. This is non-cardiovascular. I think it's the same in the beginning because that's before the pandemic. Then the pandemic comes and it separates. If you look at time from infection, look what happens. The curves are very different. Fewer deaths adjudicated directly to COVID. So time since first COVID diagnosis, they collect this in the trial. Look, it's protecting against COVID deaths. We don't even have any other meds like this. Maybe Paxlovid, but 5 days acute treatment for whether people get hospitalized. This is chronic treatment that protected people. Fascinating. And again, like I said, this drug is known to modulate inflammation. So really great editorial by Jeremy Faust, if you're interested, exploring this issue, cardiovascular, non-cardiovascular. I think it's because cardiometabolic derangements actually cause susceptibility to cardiovascular deaths, but maybe also to other things like inflammation. Creates an inflammatory state. And that may cause harder to have responsiveness to infectious challenges. So this is quite interesting. We cardiologists may be treating cardiometabolic risk, but we're helping them be resistant to a wide range of threats. I talked to you about flow. Flow also showed improvements against heart failure. We published this paper across a wide range of things. Quickly, I was showing you semaglutide. Tirzepatide, we're seeing the same thing. Summit's going to be presented at AHA. That looked at heart failure with preserved systolic function. They also looked already at obstructive sleep apnea you heard about. I guarantee you the outcome study for tirzepatide for secondary prevention is also going to be positive. I fully expect it to be. Summit was stopped early, not stopped early, right, Chris? Wasn't stopped early, but completed, but is an outcomes trial, has outcomes. And they had to report already in the US because of it's a publicly traded stock. Lilly has to report. Already they say 38% reduction in time to first occurrence of heart failure outcomes. Amazing. Not just quality of life improves, but outcomes for people with heart failure and preserved systolic function. Chris's paper is going to show quite a lot of insights using the MRI, CMR, and be quite interesting. So we have a variety of papers coming still in JACC from AHA. This one I'm pointing you to is the one Chris talked about. So these are the implications. These are not just weight reducers. They're health promoters. They may provide highly effective strategies to reduce individual risk, promote population health. Again, we have to change how we think about obesity. You know, in China, it's very easy to, like US too, say people, pang, you know, it's, we can say, you know, people have it, and there's stigma. You know, we in medicine have to change that idea. We have to change that idea if we're going to help people to reduce risk. And obesity is rising in China, just like everywhere else in the world. Given their effectiveness in improving outcomes, there is imperative for us to improve access to these meds, continue learning, optimize their use. This is a huge opportunity for us to improve population health. Thank you. 谢谢。